Thank you, Puj. I'd like to thank the IPC too for the opportunity to be here with you today. And we're discussing psoriasis treatments and chronic infections. These are my conflicts of interest. So we know that different classes of drugs used in the treatment of psoriasis present a higher risk of some specific infections, such as, for example, here on the upper left, the occurrence of peritoneal tuberculosis in a patient under anti-TNF treatment, the occurrence of candidiasis and even of dermatophyte infections during anti-IL-17 drugs, and even the risk of herpes zoster during the NeuroJAK inhibitors. But when we talk about the risk of infections, when do specifically these side effects tend to occur? Is it mostly at the beginning of treatment? Is it mostly during some years of therapy? Here we present data from the Swedish biologics registry evaluating anti-TNF therapies, showing higher risk of infections during the first years of treatment. The most commonly reported infections were respiratory infections, gastrointestinal, and skin infections. Similar data we have from the British Society of Rheumatology registry, showing a higher risk of serious infections with anti-TNF drugs, namely etanercept, adalimumab, and infliximab, during the first year of treatment. And this occurs opposite to what we see with the DMARD treatments, where the risk of infections tends to be higher later on during the treatment. Concerning the use of interleukin blockers, we know that the risk of infections tends to be stable throughout the years. Here we see that the rates of infections, for example, with ustekinumab during the pivotal studies, tended to remain low and stable during all the 5 years of follow-up with this modality treatment. But is there really a higher risk of serious infections when we talk about treatments of patients with psoriasis? Here we see the results from a systematic review of the literature, evaluating randomized controlled trials and really showing no risk of serious infections with the use of anti-TNF blockers. This was published in 2011, and the risks were not higher for the psoriasis patients and also not for the patients with psoriatic arthritis. Here we see data from the British Association of Dermatologists, also showing no increased risks of serious infections for anti-TNF drugs. Here, specifically when compared with non-biologic therapies as methotrexate. Here, having a look at the SOLAR registry, we note that the risk of infections with the IL-12/23 blockers are lower, specifically when compared with anti-TNF drugs as infliximab, and comparable to the use of non-biologic treatments. More recent data showing systematic reviews of the literature and meta-analysis published now last year, evaluating the IL-17 and IL-20 and 23 blockers, also presented no increase of serious infections with these newer treatment modalities. The authors also had a look at the candidiasis infection, and we know that there is a specific group of patients, those ones using IL-17 blockers, that have a higher trend to develop candidiasis due to all the mechanisms of IL-17 blocker, IL-17 interleukins in protecting the body against this kind of specific fungal infection. And what about specifically chronic infections as tuberculosis? Here we see very recent data from the World Health Organization stating that about 1/4 of the whole global population is estimated to be infected by Mycobacterium tuberculosis. Nowadays, worldwide, tuberculosis is considered the 13th leading cause of death and the second leading infectious killer only after COVID-19 infections, and even above HIV and AIDS. In 2021, there was an estimated 10.6 million people falling ill with tuberculosis, and a total of 1.6 million people dying from tuberculosis in 2021, including over 180,000 patients with HIV. We know that the general population, when presented latent tuberculosis, have a natural tendency of reactivation during their lifespan, and this seems to affect more specifically some groups of patients, those ones with compromised immune systems, of course, those patients living with HIV, those patients with malnutrition, diabetes, and even smokers. Here we see our beautiful city of Rio de Janeiro in Brazil. But we also know that although being such a nice city, Rio de Janeiro nowadays is considered the city with the highest incidence of tuberculosis in Brazil. We see here Rio de Janeiro at first point, just being followed by the Amazon area concerning the incidence of tuberculosis. We know that when we use anti-TNF blockers, we have a tendency for the TB granuloma to be broken down and allowing the dissemination of mycobacteria. So the risk of reactivation of tuberculosis is specifically high in this group of patients with anti-TNF blockers. And when we compare the 5 to 10% high risk of reactivation at the normal population, during anti-TNF blockers, this risk may be up to 9 times higher when compared to the normal population. Here, just to exemplify, this is one of our patients at the Hospital das Clínicas in São Paulo. This patient had a brother with tuberculosis, but he denied this information when being evaluated for the first time because he had heard that perhaps patients with a history of contact tuberculosis would not be permitted to receive biologic treatment. So he omitted this data. It was about 10 years ago. And so when he started his anti-TNF treatment, after a period of 3 to 4 months, he started to develop ascites. And here we see his picture with the diagnosis of peritoneal tuberculosis. Here, another case of ocular tuberculosis. We know that in many instances, cases of TB are extrapulmonar and extrapleural, and we have some very rare and specific manifestations also being reported as this is a specific case, and even more rare here, a case of tuberculosis affecting the tongue of a patient during anti-TNF therapy. But we know that since adequate screening and chemoprophylaxis started to be introduced here about the year 2001, here we see data of the infliximab risk of tuberculosis. We see how dramatically it tends to drop after this program was initiated in a worldwide fashion. And what about traditional systemic therapies of psoriasis? Is there also a risk of reactivation of tuberculosis? Here we have data from the Swedish registries looking at patients with rheumatoid arthritis specifically, showing that methotrexate was not associated with an increased risk of tuberculosis, specifically when compared to other drugs like leflunomide, azathioprine, and specifically prednisone that presented a higher risk of reactivation. We have some specific publications looking at IL-17 blockers. Here we see the group of patients being treated with these drugs during the pivotal clinical studies. In both groups, quantiferon tested positive and negative patients, no cases of reactivation of tuberculosis. There's a specific group of patients that was treated with risankizumab, the IL-23 blocker, during the ENHANCE study, out of which 31 patients that were diagnosed with latent tuberculosis did not undergo the traditional prophylaxis of these diseases. And during a follow-up period of 55 weeks, no single case of this group of 31 patients reactivated tuberculosis. We have some expert opinions published in the literature. This one by the group of Mark Lebwo, an up-to-date review published in 2009, stating that in general, it's safe to use IL-17 blockers and apremilast in patients with latent tuberculosis, that anti-TNF drugs and ustekinumab can be used for patients with psoriasis, but only after the adequate tuberculosis screening and prophylaxis has been initiated. We need additional data for the new IL-23 inhibitors, but we know that what we know so far from case reports and literature reviews, this class of drugs also seems to be very safe. Methotrexate and cyclosporine can be used in patients with latent tuberculosis, and we know that acitretin, also a not very effective drug, is considered one of the safest drugs to be used in this setting. And what about another chronic infection, hepatitis? We know that the presence or absence of hepatitis in our psoriasis patients is among the factors to be considered when deciding which approach we'll do to our patients. Patients with a history of or currently active hepatitis C, we know are a safe group to be treated with anti-TNF blockers, anti-IL-17, and even IL-20 and 12 and 23 blockers. But we always state that the concomitant management with the appropriate health care provided is mandatory for these patients. Patients showing a positive serology of hepatitis B should always be seen by a specialist, and in cases where it's indicated, prophylactic antiviral treatment should be started. In those cases, lamivudine and entecavir should be started prior to initiating our biologic treatment. When we are to start this prophylaxis, it should be started at least a couple of weeks before the administration of the biologic drug and continued at least up to 6 months after biologic treatment has been discontinued. Here, another expert opinion publication recently out in the literature looking at hepatitis B and biologic systemic treatments, where the group of experts, including Alexander Ekberg and Yashin Wu, states that in this group of specialists, one of the first class of drugs that should be an option for patients with hepatitis B should be IL-17 blockers, followed by IL-23 blockers, and then as a third class options, ustekinumab or anti-TNF inhibitors. We have some specific publications looking at specific classes of biologics. Here we have a study looking at a group of patients treated with secukinumab, and during all this follow-up study of patients under treatment with secukinumab, there was only one single case of reactivation of both hepatitis B and C. But this patient is specifically out a group of 60 patients had done no prophylaxis and no treatment before trying secukinumab treatment. And to finalize, HIV, we know it's always an issue when we make an option for our patients with psoriasis treated and have this infection also. We know that patients with the HIV virus have a higher prevalence of psoriasis, have a similar prevalence of psoriasis when compared to the population, but when not treated for the HIV infections, these patients tend to be more serious and have more aggravated cases. The incidence and severity of psoriasis will correlate with the HIV load, and we know that it's essential to treat the HIV specifically before starting any specific treatment for psoriasis. We know that drug-related benefits and risks when treating a patient with systemic psoriasis are similar for non-HIV patients and patients with a suppressed viral load and normalized CD4 counts. Before initiating psoriasis treatment, we should always address HIV replication together with the HIV specialist. And treatment decisions should, of course, be made case by case. And here to finalize, the same review by Mark Lebwo stating which biologic treatments would be safe for patients with psoriasis. and stating that TNF blockers, ustekinumab and apremilast, might be the first option. And once again, apremilast acitretin considered a very safe option for this group of patients. I thank your attention.